Okay, so as you said, I'm Jafar Hussain. I'm one of the urologists. I'm based out of Centenary. And this was a presentation that I gave at our surgical rounds, our surgical grand rounds previously. And Dr. Hummel thought it was something that would be nice to present at medicine grand rounds. So here I am. So the topic I'm presenting on is frailty in urologic surgery. I'll start by going over a case, and probably a patient like this is not so unfamiliar to internal medicine. So is that, oh, there. So this is an 86-year-old gentleman. His medical history, specifically with regards to urological history, he has BPH. He's had a previous open simple prostatectomy in 1998, followed by a TURP because of regrowth in 2015. Unfortunately, he has an acontractile bladder, so his bladder doesn't squeeze. So he has persistent retention, and he self-catheterizes. He does develop recurrent bladder stones and has had multiple procedures to address that. He otherwise has hypertension, visual impairment. He's on a couple of medications for his hypertension as well. From a social history perspective, he has no family that lives with him in Toronto. He lives alone. He's independent for all his activities, and at baseline ambulates without a walker. He was brought to the emergency department after being found at home cachectic, lethargic. He had a 3-week history of increasing weakness, weight loss, falls, and decreased PO intake. He was admitted to medicine for functional decline, malnourishment, AKI, and a UTI. And during his admission, he developed hematuria. A CT scan was obtained, which showed a bladder mass along his left bladder wall with some associated hydro. Cystoscopy was carried out, which showed some nodularity along the left side of the bladder, concerning for a bladder tumor. He underwent a resection of this bladder tumor. It demonstrated muscle invasive, poorly differentiated SCC of the bladder. However, his CT scan demonstrated no evidence of any metastatic disease or lymphadenopathy. He did remain in hospital for about 3 or 4 weeks. He still remained well below his baseline despite having his UTI addressed, his hematuria, his bladder cancer, and he was well below his functional baseline with decreased oral intake. And it sort of persisted that way. And after a discussion with the patient, he decided for a palliative route and was transferred to a long-term palliative care unit. And subsequently, the patient did pass away. So a case like this sort of brings to light the idea and the concept of frailty. So there's many definitions and there's many ways to score it, but generally speaking, it's a medical syndrome with multiple causes and contributors. That's characterized by diminished strength, endurance, and reduced physiologic function that increases a patient's vulnerability to developing increased dependency and or death. So I guess in a way, it attempts to estimate a patient's physical reserve. And so there are terms that are synonymous, or we think that are synonymous with frailty, but there are differences. So aging, if we strictly look at aging, not all older adults become frail. From an idea of disability, frail individuals can be disabled, but not all disabled patients are frail. Sarcopenia can be a characteristic, but not necessarily a defining feature, and multimorbidity. So this is obviously something that's becoming more pervasive. And so if that was just looking at multimorbidity as a sole factor, a large portion of our patient population would be sort of considered frail. So when we look at prevalence, it's a wide range based on what definition you use, anywhere from 4 to 16% of women and men over the age of 65. And more specifically, when we look at patients with cancer, it can, approach somewhere close to 40%. And why is this important? So I think if we look at the trend in our population growth, if you looked at the population in Canada back in 2002, the majority of our population obviously was in their 40s and 50s, and so those are the baby boomers. And when we look as time goes on, so this plot looks at 2022, we're really seeing that silver tsunami. So basically, the majority of patients that we're seeing are over the age of are either around the age of 65 or older, and that number is only going to continue to rise as time goes on. So it's something that we also take a look at when we look at surgical patients. So these are different specialties, and look at the breakdown of age of the patients that are treated, and the majority fall in the 65 plus range. So it's definitely something that we see in surgery as well. So when we look at frailty and surgical outcomes, there are many things that can predict surgical outcomes, but frailty has been repeatedly demonstrated to be an independent predictor of mortality, morbidity, extended length of stay, and institutional discharge among elderly surgical patients. And so that's kind of the reason why it's becoming a growing concept and concern and a focus in surgical programs. When we look at pathophysiology, there's different ways that it can be described. So there's sort of the frailty phenotype, which is a condition of weakness, weight loss, and physical decline. So basically, it's the age-related cellular physiological changes that lead to vulnerability. So it's more of a state. The accumulated deficits theory is a bit different in the sense that vulnerability is a result of accumulated sort of insults, so medical, physical, social conditions. And the idea is that you lose robustness because of these multiple insults. And so there's two different ways that you look at them. And I think when you look at the extremes of patients in terms of frailty and you compare the two models, it works well in terms of explaining it, but it's somewhere in between where you sort of they don't really match up. So this is sort of a schematic explaining the two. So a biologic-driven frailty model versus a deficit-driven model, where one is a state and one is an accumulation of insults. So how does this play into preoperative risk assessment? So how can we apply it to surgical patients? So I think there's a gap in knowledge, but there's been a lot of focus on frailty in surgery over the last 2 decades. So I think there is definitely a need for better risk stratification and treatment selection based on frailty status. And as I mentioned before, age alone doesn't correlate with risk. When we look at single end organ function assessments, such as cardiac testing, renal function, pulmonary function, it doesn't necessarily capture all the information to predict adverse outcomes. So how do we measure it? And there's many scales to do that. You know, some are more involved, some are very time consuming, some are sort of self-administered, some are questionnaires, but there's different types, and a few of them have been validated in different studies in surgical applications. So there's like the frailty phenotype, there's a Edmonton Frail scale that's self-reported, and it's difficult to know which one to use. I think for the most part, the frailty index scores, so it takes into consideration different metrics such as nutrition, physical activity, falls, age, other comorbidities, and something that's relatively quick to administer. It takes about 2 or 3 minutes. So this is the frailty risk analysis index. So it's 14 variables. There's a weighted score, and it takes about 2 minutes to administer. And it's been proven to predict 180-day mortality in previous studies. How about the eyeball test? Like, we see patients in clinic, we say, oh, that patient's frail. So this was a study that looked at comparing a urologist eyeball test with a formal geriatric assessment. And just based on an eyeball test, 50% of frail patients are missed. So we're not that good just, pointing them out from our waiting room. So a better sort of assessment is needed. Sometimes you think, are there single items like surrogate assessments for frailty? And there are some. So slow gait speed, so they measure the speed of their ability to walk over a 5-meter distance. Get up and go score, that's something that we can definitely, like as surgeons, use in the waiting room when we see patients and we get them up. So something greater than 15 seconds is sensitive and specific for identifying frailty. And these can be sort of as quick screening guides. So how effective is it to screen for frailty in a surgical setting? So this was a study that was conducted where they implemented a screening initiative in 2011. And basically, after patients were screened and identified, they would alert the operating surgeon, they'd alert anesthesia, and a referral was made for a palliative care consultation. That's just the system that they set up in this study. So when we look at it, so on the left hand, prior to that dotted line, the vertical dotted line, there was no screening and no flagging of any frail patients. But after the implementation of this screening program, you notice that there was a decrease in 30, 180, and 365-day mortality across patients with frailty. So this is just sort of to goes to show that, if these patients are identified, so there can be intervention preoperatively to help postoperative outcomes. And so the question is, a lot of studies focus on patients in high-risk settings. So this was another study looking at frailty and postoperative mortality in high-risk surgeries. So it was a population-based study from 2002 to 2012. Patients 65 and older who had gone various intermediate to high-risk surgeries. At 12 months postoperatively, about 13.6 versus 4.8% of non-frail patients had passed away as a result of their surgeries. When we look at urological procedures in general, if you look at nephrectomies and cystectomies, if you look at the percent mortality, these are absolute rates. So 17.1% of nephrectomy patients versus 9.2% of non-frail patients. And in cystectomy, it's even more, which is an even more morbid surgery. So there is certainly a risk with frailty and these major types of surgeries, and this sort of applies not only in high-risk procedures. It's also something to consider in low-risk procedures. So if you look at this plot here, they basically mapped out patients across different severity in terms of based on frailty index. When you look at low-risk procedures, so those procedures in which we would quote less than a 1% chance of death versus high-risk procedures, so risk of greater than 1% of death, that concept of 30-day mortality is present with increasing more frailty. So it's not a concept that strictly applies to patients undergoing major procedures. So this is another study looking at that specifically, but they break it down even further into types of operative stress. So this is a retrospective study of 480,000 patients. 8.5% were frail versus and 2.1 very frail. So if you look at this table here, they categorized operative stress score from categories from 1 to 5. So 1 being very low stress to 5 being very high stress. And examples of very low stress would be something like a hydrocele resection or any small sort of cystoscopy under general anesthetic. And something very high stress would be something like a cystectomy. When they looked at 30-day and 180-day postoperative mortality based on stress and frailty, again, you see that those patients who were in the highest risk category for frailty had a higher level of postoperative mortality across the different category levels for operative stress. So again, displaying that, it's not just in major cases that we need to worry about these patients. This was a study looking at frailty index to predict outcomes after radical cystectomy. So they compared predictive value of frailty with other methods that we use to assess operative risk in the elderly. Because it was sort of a retrospective study, they looked at 5 items as the simplified frailty index. So looked at patients who were diabetic, functional status, COPD, CHF, and hypertension. Basically, looking at this breakdown, the major factors that contributed to postoperative complications following radical cystectomy were, weight, which we already know, smoking status, which we know already, but also when you look at the bottom at the simplified frailty index, as frailty increased based on their measuring index, so did the rate of complications. So it is a predictor on its own of postoperative complications in major urological procedures. Another study looking at sort of short-term outcomes after radical cystectomy based on frailty. So this was 9,000 patients from a nationwide readmission database. 7% were identified as frail. And these patients who were frail were found to be more comorbid. They had higher rates of in-hospital mortality compared to non-frail patients, higher levels of ICU level complications, increased length of stay, and obviously a higher median cost because of their admission. So there's definitely something to be said, even if it's not, we're talking about mortality, but it's all at all levels where it could be impacted during their hospitalization. And as I mentioned, it's not just applicable to major procedures. There are studies that look at different sort of urological procedures that are conducted, and basically, this study looked at 21 different urological procedures using NSQIP data, and they used a different type of frailty index based on the NSQIP data that looks at 11 different items. And as frailty increases, complication rates increase as well. So more and more studies are identifying this, and these results are reproducible. So is it just surgeries that we see that that where frailty plays a factor in? And it's more than that. I mean, we see patients who have urinary retention requiring chronic Foley catheterization, or patients who with urinary incontinence. So this was a study that looked at the association of urinary incontinence and mortality. It was a retrospective study done at Sunnybrook and Toronto Western. So this looked at patients, about 2,000 patients over the age of 50. So there was a significantly increased risk of mortality associated with urinary incontinence. However, this was only identified among frail patients. And stress urinary incontinence and urge urinary incontinence were independently associated with frailty increase in 13.3 and 18.4% respectively. So it's not just necessarily surgical patients that we're seeing, it's other patients who have other urological conditions as well. And so basically all this data is presented and collected, and people are focusing on this. And the idea is, so how do we apply this? I mean, how can we identify these patients and make a difference in terms of their surgical outcomes? So I think by identifying these patients and stratifying them preoperatively, it helps in preoperative counseling and preparing patients for surgery. So identifying patients who may require optimization prior to planned surgery, or those who may require resources from allied health partners post-operatively. One concept is sort of the idea of a comprehensive geriatric assessment in preoperative phase. So not only that, but also the idea of prehabilitation. I mean, we do. I mean, the concept of sending patients for rehab following surgery or admission is very well known, and that's something that that's practiced. But the idea of prehabilitation is something that's emerging. So they've looked at preoperative exercise programs. So exercise-based programs alone don't demonstrate significant improvement in main physical and surgical outcomes. From a multimodal approach, you have to consider exercise, nutritional therapy, but also psychosocial interventions as well. And that's the whole idea of prehabilitation or comprehensive geriatric assessment. So it's a multidimensional, interdisciplinary diagnostic process. So looking at the medical, psychological, social, and functional capabilities of a frail elderly person, and developing a plan so that you can optimize these patients for surgery and prevent a lot of the complications or mortality associated with these surgeries. And this was a study, so it was a systematic review looking at comprehensive geriatric assessment for older people admitted to a surgical service, and they found that patients who received these assessments were likely to have lower risk of dying, and that after discharge were more likely to return to the same location they lived in before hospital admission. So this is sort of an idea of where prehabilitation would fit into the perioperative course. So the idea is that it's preoperatively, these patients are flagged from the surgeon's office, sent for a referral, and that way they can be participating in these types of programs. And so They've looked at these types of programs, specifically with regards to urological procedures. So a multimodal rehabilitation program to enhance functional capacity following radical cystectomy. This was a randomized control trial. 70 patients who were scheduled for cystectomy, 35 were on the control group, 35 went to prehab. Mean age was around 69. And the primary outcome was a change in functional capacity measured with the distance covered during a 6-minute walking test. And the result ultimately was that there was a faster recovery to their functional baseline after radical cystectomy. And this is plotted here. So you could see at baseline, prior to randomization, they're sort of they're at equal. At pre-op, you could see that. So these patients who are went through the pre-op program, they have a improvement in their walking distance score. Obviously, 4 weeks and 8 weeks post-op, there is a decline, but definitely a significantly less of a decline in patients who underwent a pre-op program. I think a big concept or issue, obviously, is that accessibility, right? I mean, how do we get all these patients to participate in pre-op programs? So there have been some studies that look at virtual programs. One of them was this idea of Prehab PAL. So it was a digital interactive service for surgical rehabilitation. 93 participants in this study. Mean age was about 71. And they enrolled for about 15 days in this program. And it was to look at basically a physical, mental, and nutritional health leading to surgery. I think some of the concept people worry about is that, elderly patients won't be able to use virtual platforms. And, despite that, 86% of these patients found that it was easy to use and helpful in sort of their program. And there have been feasibility studies looking at the application of rehabilitation programs. This one was recently published and based out of UHN. So they have a large, actually, rehabilitation program there, mainly in organ transplant and oncology programs. I believe they have enrolled, since they started in 2019, about 1,500 patients who have gone through this program. I think they average about 6 patients per month. The average the median time in the program is about 36 days. And it's definitely something that's helped, and they've seen improvement based on this study here. So it's definitely, like I said, a growing concept. A lot more hospital programs are implementing this. It is available at Sunnybrook. It's available in the hospitals out west in the Credit Valley and Mississauga programs in Halton region. I don't think a program like this exists here in Scarborough, and so it's potentially something that can be of interest and applicable in our patient population. And that's it from my perspective, if anybody has any questions.
Thanks for that great presentation. And I think for those of us who are working in pre-op clinic, I think very relevant, thinking about, as the data suggests, even lower risk procedures, frailty can have an impact on outcomes. And really for us, the focus on our risk assessments is on inpatient procedures. And so I think it's really timely that that we actually have that data. I can't see if there's any other hands up for this moment, but I guess as of this moment, having kind of reviewed some of these, is there, in terms of your own practice and assessments, is there one of the tools kind of been the one that you've either incorporated or would be the first to incorporate from what you've seen?
Like what tools do we incorporate? Like
in terms of the frailty, which frailty? Of the
yeah, I mean, I think the relative the risk assessment index, the one that I mentioned before. I mean, I don't use it for all patients, and I think part of it is an eyeball test, or it is looking at sort of those surrogate markers like the get up and go or like, in my office specifically, there are 2 long hallways before I get to my office. So it's that walking distance and also the get up and go. So those are sort of surrogate markers that I use, for example. Now, I mean, we don't have a prehabilitation program or a comprehensive geriatric assessment program that I can refer these patients to, but these are patients who are flagged. These are patients who, I'm going to take a different, get a better understanding of their functional baseline, nutrition, their social supports, all these other things. And obviously patients who would be flagged for, consideration of maybe a medicine assessment or in addition to their anesthesia assessment pre-op.
Thanks. And I was going to mention there are multiple geriatricians on this call, but
yeah, for sure.
Shara has her hand up, so I'll let her.
I do. Can you hear me?
Yeah.
Amazing. Thank you so much for this incredible talk. I'm so excited that first of all, it's coming from the surgical side of things, which is so amazing. Yes, so we actually are really trying to broaden our program so that we have the capacity to do as many perioperative assessments as possible. We have, kind of in the shorter perioperative course, we have our consult service, which anybody can consult us to do a pre-op delirium assessment. We put in multimodal assessments, interventions at that point, but we also have the GAIN clinic. And when we follow people in GAIN clinic, if we're aware that they are candidates for surgery or they're being offered surgery, we will do that multimodal assessment. We don't have a prehab program, but we often refer people to the falls prevention program or to in-home physiotherapy or something like that beforehand in preparation. So if we know that this is going to occur for people, we will kind of pull that trigger and think about ways to prehab them. We look at their mental health, we look at their cognition, we counsel them on the expected things to look out for in that perioperative period, and we look at their nutrition and eating habits and might add supplements or something else at that time. So we are trying to get all of this great stuff accessible. And feel free to refer people to get a CGA if they're coming up for operations, because we are prioritizing them to be seen in clinic. We've done it for TAVIs a couple of times, and we can definitely do it for other procedures.
So for outpatient, it's the GAIN clinic.
You got it. So
Okay,
if you say GAIN clinic, geriatrician, coming up procedure, we're concerned about their risk, high risk, high frailty. Can you do something to optimize? We'll prioritize to try to get them seen so that we can do something about it.
Okay, that's great. And then you said also for inpatient assessments as well, right?
Yes. So we have our geriatric consult service and we're open at all 3 sites. So if somebody is admitted to any of them, you can just put in a consult to GMCS and we are happy to see them.
Awesome. That's great to hear. Perfect.
Yeah, one thing medicine needs to do better is advertise.
Get the word out there, yeah.
An email
I think part of it also is just like I think from a surgeon perspective, I think it's different working maybe at these academic centers than it is at, community sites, because a lot of the programs that exist probably at our academic centers, and there may be a lot more resources around surgeons as well, like not just like other discipline, but within their service as well. And so even if it's not them, directly identifying these things or sending them out to these clinics, it's someone on their team or around them. So I think it's something that as surgeons, like you mentioned before, it's something that I think have to identify, because if there's any way that we can sort of improve these patients' outcomes post-operatively or prevent an admission to hospital or whatever it is, or getting them back to maybe where they were before they had their surgery, then I think that's huge. And I think a lot of the times also we see patients and we say, you're just not a surgical candidate based on sort of how they look or whatever. But I don't think there comes the idea of sort of how can we optimize them, or who else can make that assessment and judgment and decide. And so I think it's important to have these resources. So it's good to know.
That's great. Any other questions from the group? And if not, thanks again for that great presentation, and I will
be reaching out to Dr. Chan.
Awesome. Thanks
Further
so much.
advertising.
Yeah, for sure. Yeah, if you let Dr. Chan know, and then they can send out an email to our whole surgical group across the 3 sites.
Great.